Yes, I mean, there are a variety of approaches that are proving very interesting, both as initial therapies that are given regardless of diagnosis or initial classification, as well as newer targeted approaches and those that might be used at treatment failure or relapse. So there's been some interesting observations that drugs such as Rituximab can improve survival rates, work from the French adult group, as well as potentially reducing some of the side effects of therapy, particularly allergy to Asparaginase. And we and other groups are now using this front line in our trials of ALL in children. There are a number of precision medicine approaches that can be tailored to mutations or mutated pathways. Some of these are the kinase inhibitors that are proving promising in kinase-driven ALL. So there's obviously a long track record of using kinase inhibitors in BCR-ABL-positive or Philadelphia chromosome-positive ALL. One of my points yesterday in the talk is this important and large subtype of leukemias called PH-like ALL that have a range of different mutations that, if you like, phenocopy BCR-ABL, that are also, we know, potentially sensitive to kinase inhibitors in several classes and several pathways. And so we and several other centres are using these either at initial diagnosis or when we see poor treatment response to try and improve outcomes. There are some other approaches as well, and clearly some of the most exciting ones are immunotherapy, and I think we've seen a great deal of enthusiasm for antibody-based immunotherapy or cellular immunotherapy at treatment failure, and now trials including ours are seeking to bring these therapies somewhat earlier in the course of disease, for example using them at initial poor treatment response as shown by high MRD levels rather than waiting till florid relapse.